We're excited to have everyone joining us today for another edition of our Accreta Expert Series live stream events. Today's presentation will feature conversation and a lot of interesting and insightful information from our guest speaker, Dr. Lisa Zuckerwise, who will be talking with us about her experience in treating Accreta, her use of conservative management and alternate treatment options. So we're really thrilled to have you all here. Thanks for joining us. As you join, would you please let us know in the comments where you're joining us from? We always love to see who in the Accreta community is joining us. And I'm just going to let a few more minutes go as more folks join our presentation today. Again, we're so glad to have you with us for this Accreta Expert Series live stream event. Awesome. Hi, I see April from Indiana, Amanda from Texas, Nova from Indiana. Wonderful. Hi, Nicole from Connecticut. Great. Welcome to all of our viewers. We're going to get started momentarily with this edition of our Accreta Expert Series live streams. We have Amanda joining us from Maine. We have Crystal joining from Australia. Casey from Massachusetts, Crystal from Texas, Olga from Connecticut, Kayla from Western Kentucky, but attends Vanderbilt where Lisa works, Karen from Maine. Wow, we've got a great group today of folks. Amy from Texas. So we're so glad to have you all with us today. Please continue to drop in the chat where you're joining us from, what you're interested in learning about today. We're excited to be with you. Before we get started, I'm just going to go ahead and share a couple of other newsworthy things with our Accreta community. We wanted to share first that we are celebrating the end of another meaningful Accreta Awareness Month campaign. Thanks to your support and participation, we spread awareness of Placenta Accreta Spectrum, engaged with our partners at the Pan American Society for the Placenta Accreta Spectrum by presenting at their annual meeting. We hosted an Accreta Live event last month with PAS Squared board member Dr. Fox. We generated blood donations, we gathered stories, we supported patients and providers, and of course we raised funds to support resources and research through our third annual virtual 5K. And we were especially pleased to crown Accreta survivor Stacy Tate as our 2022 Accreta Awareness Champion for her fundraising efforts. There's still time to chip in to the campaign, so please consider doing so. And I also wanted to share that there will be more opportunities for getting involved and giving back coming up very soon in the month of November. Following Thanksgiving on Cyber Monday, we encourage you, if you're not already enrolled, to support the National Accreta Foundation through your Amazon purchases. Please choose us as your charity of choice on Amazon Smile. And when you go to do some of that Cyber Monday shopping, you can benefit maternal health advocacy as well. And then immediately following that, on November 29th, will be Giving Tuesday, and your donations can be matched. You'll see a Giving Tuesday campaign on our Facebook page, and we encourage you to consider giving back to support our mission and other Accreta patients, moms, and survivors like you. I wanted to also give a shout out to the new gear that we have available in our gear center. This is a great way to show your Accreta pride and also to give back to our mission. So without further ado, because we have so many people excited to be with us today, I'm going to go ahead and bring up Kristen Terlizzi. Well, and before I do, I just want to briefly kind of give one word of particular invitation today, because we know that this topic in particular, conservative management, can sometimes feel sensitive or triggering for members of our community. I was just sharing with Dr. Zuckerwise before we got started today that I had a brief period of conservative management in my own Accreta treatment. So, we just ask that you engage respectively, compassionately, that you give yourself permission to sign off if you're not ready to engage on this topic at the stage that you're at in your journey. And remember that these live streams will remain available to view on demand on our website. So we look forward to it being available to you when you're ready and for future patients and providers too. So please, this is your space. Engage with us throughout, and I'm pleased to turn it over to the National Accreta Foundation's board president.
Hi, everyone. Thank you, Jory. That was a fantastic introduction. So excited to be here today and hosting this session. I'm Kristen Terlizzi. I'm a Placenta Accreta survivor based here in Northern California. I'm also a co-founder of National Accreta Foundation. And thank you all so much for joining us today. I want to give a big thank you and a shout out to everyone who has been participating in Accreta Awareness Month. It was so fun to see you guys sharing the posts, raising funds, getting the word out about placenta accreta as one of the fastest growing life-threatening complications of pregnancy. So Accreta Awareness Month is always a big month for us here at National Accreta Foundation. It was especially exciting this year as we were in Utah a few weeks back at the Pan American Society for the Placenta Accreta Spectrum annual meeting. And we got to see Dr. Zuckerwise there as well. We had some great conversations, and we are just so fascinated by the research that she is doing, leading the way in conservative treatment. So it's something we see coming up, the topics in the groups. We see folks discussing it. And so we really wanted to bring you guys the latest and greatest information from Dr. Zuckerwise herself and have her here to answer questions. Oh, I love that picture. That's her shoes doing her 5K for Accreta Awareness Month with the Accreta Strong shoe charms. There she is. Thank you. Okay, and so with that, let's go ahead and bring her on. So excited to welcome you, Dr. Zuckerwise. Thanks for being here.
Thank you so much for having me. It's good to see you again.
Yes. And so to let you guys know who aren't familiar with her work, Dr. Zuckerwise is currently an assistant professor of obstetrics and gynecology and the associate program director of the Maternal Fetal Medicine Fellowship at Vanderbilt. She completed her residency and fellowship in OBGYN and MFM at Yale. And her clinical and research interests include congenital anomalies, fetal diagnosis and therapy, and novel approaches to managing placenta accreta spectrum, which is what we are here to discuss today. So I would love to start off, Dr. Zuckerwise, if you could give us a little information about your facility. How many accretas do you guys see a year?
Yeah, thank you. First, before I start, I do want to, you mentioned I did my training at Yale, and I just want to give a shout out to all my old friends from Connecticut who are joining today. They basically raised me as an obstetrician, and so it's so wonderful to see your names popping up. Thank you for being here. I would say at Vanderbilt, our numbers, like everywhere, are increasing, and so probably upwards of 10 to 15. Maybe even topping 20 a year at this point. But it definitely seems that something that comes in waves, that we'll have a month where we have several cases, kind of take a month off and then come back again. But they're growing. It's an increasing problem.
Absolutely. And so since you guys are experienced in treating placenta accreta, I'd love to hear, how do you address the complexities of an accreta delivery from a patient experience standpoint? So kind of outside of the medical treatment, how do you support these moms and families?
This is such an important topic, and something that I will get into when we get into my slides. Something that I think you and I have spoken about that we really haven't historically focused on as much. We've been so focused on surgical diagnosis first, surgical preparation, surgical expertise, and surgical management, that up until I think quite recently, and really some of the research coming out of Utah and some of the stuff that we're doing, talking to past patients, and of course what's going on with NAF, there's really been a shift to realizing that once we get out of the OR and we think we're out of the woods, our patients are not out of the woods, and that there's so much more than just a surgical case or a pregnancy to deliver that goes into accreta care. And so I think, all of us taking care of patients with any number of complex conditions really have to see the patient as part of a family, as part of a community, as part of, the world that has life experiences that are affected from the diagnosis and long past the medical conclusion of their Accreta. And so kind of honoring that from the first time we talk about the diagnosis, kind of sharing with patients that what you're going to hear is this is a really big deal. That's not lost on me. I know it won't be lost on you. And let's just keep talking about what you need physically, emotionally, and otherwise for support. So at Vanderbilt, we have social workers involved. We often get our psychiatry colleagues involved who have expertise in perinatal depression and anxiety. And we just keep an open communication with our patients to say, we know what's going on and we want to be there for you in all facets. I was able to have a few of those little packets from NAF of the little bags that have all your information. So I also shared those with patients. And then something that's been so amazing that's been happening recently is some of our patients have been coming back saying they want to be able to walk through this with other people and offering that if we have patients who have had this experience, they would be their Accreta guides or Accreta supporters, people who truly know what they're going through in a way that unfortunately, or fortunately, the majority of people around them can't.
That's such an important point too. The Accreta community is a strong one, and it's such a unique experience that going through it and being able to give back and support those who are at different points in their Accreta journeys can be such a powerful thing for everyone. So thank you so much for understanding the complexities of the experience, and it's great to hear the work that you guys are doing to get these women through this. So I have a few questions just about Accreta for you as well. Do you think Placenta Accreta gets as much attention as it should?
No, I don't. No, I mean, I don't.
No
I
pause.
think, yeah, no, I mean, I don't because there, even patients who are coming to us for suspected Accreta who have had a prior C-section, most of them have never heard of Accreta. And so recognizing that cesarean delivery is going to be the biggest risk factor for future Accreta, it would make sense that cesarean section, which is also the most commonly performed major surgery in our country, that every patient who undergoes this, when we're talking about risks, benefits, and alternatives, that we mention this as a known risk, as a known complication, and that again we remind them of this risk if we're talking to them about the potential for a trial of labor after cesarean and deciding between that and a repeat cesarean. Now, I am so glad that we can do cesarean deliveries. It saves so many lives and preserves the health of so many moms and babies. But we all have to be better about doing it really only when it's necessary and only when the patient has had the benefit of a true risk benefit conversation to decide what is best in that situation. And so I think that every single person who undergoes cesarean delivery should understand what Accreta is because it may impact them in the future.
We couldn't agree more. And that's actually one of the most common complaints that we hear within the Accreta community is that the first time people hear the word Accreta, even if they have many risk factors for it, is when they're diagnosed. So we would love to see that shift as well. So how did you first hear about Accreta and how did you end up focusing your career on it?
Well, I mean, it's something that we hear about in medical school very briefly in our OBGYN clerkship, if we're lucky or unlucky to have, wonderful physicians who teach us about it. And then, of course, there's always patients, that impact you. And for me, I will never forget a patient that I was involved in caring for my intern year who came in with Accreta and just the way her surgical course, her care impacted the family, impacted our team. It was clear that, we had so much to offer, but also still need more for our patients. And so I think that, that kind of showed me that this was an area that needed further surgical and research investigation, not only into how to take care of it, but why it happens and can we prevent Accreta? Because that's obviously going to be the best thing that we can figure out if we can. And then I will say, just joining a team at Vanderbilt who is so open to innovation, so open to every single patient situation, thinking, what is best for this patient? Could we do better? Looking back and say, could we have done better? What do we know? What don't we know? And how can we learn more? I think it's just it's the reason I went into academic medicine, to find answers to questions that don't have answers. And so it really just, it's so such an important topic, and one that I'm happy to even contribute a tiny bit to.
So let's dive into the topic a little bit more. Can you tell us, what is conservative management?
Yes, and I will get into this, but this will, I'll fly through some slides. But so traditionally, conservative management is delivery of the baby and leaving the placenta in situ, or in the uterus. So traditional management of placenta accreta, and that which we do most commonly, is what's called the cesarean hysterectomy, meaning we go in like we're doing a C-section in the operating room, we deliver the baby, and then we go right into doing a hysterectomy to remove the uterus with the placenta attached. Conservative management is uterine sparing or uterine preserving, meaning that we leave the placenta inside and don't do the hysterectomy portion. There are different iterations or kind of combo treatments where some people have described removing part of the placenta but leaving the uterus intact or in situ, or have just removing the part of the uterus that has placenta abnormally attached to it. But when we're talking about true conservative management, it's also known as expectant management, where we just deliver the baby and close back up the uterus with the adherent placenta inside.
Fascinating. I can't wait to get into all the details in your presentation. But before we get into that, I did want to ask you a few little fun questions first. Is, what job would you have if you weren't a surgeon?
It's a job I've had in the past, and so I feel very prepared to say that I'd absolutely be delighted to go back to it. I was a scuba instructor all through college. I actually certified my mom so that someone would be able to go diving with me on family vacations, and so I would be delighted to go back to teaching scuba, maybe after retirement.
That sounds awesome. And what would people be surprised to know about you?
I'm a very big Grateful Dead fan.
Nice.
My children think that Jerry Garcia is their real Uncle Jerry.
Nice. That's fun. Okay, great. Then I'd say let's go ahead and dive into your presentation whenever you're ready.
Sure. Just let me know because I can't see you. I'll share my screen. How does that look?
That looks great.
Okay, perfect. Well, thank you so much, Kristen, Jory, and everyone from NAF. I'm really excited to be talking about alternative strategies for the management of Placenta Accreta Spectrum. This gives me a great outlet to talk about something that I find so inspiring, so important, and so exciting, without having to torture my residents and fellows every single day with it. I have no disclosures to report, and I do have just two disclaimers. This is not a talk to convince anyone of a single best approach to Placenta Accreta Spectrum, or PAS, because the truth is that we have more questions than answers. And we physicians don't often like to admit that we don't know, but with Placenta Accreta, it's truly the case. We just don't know what's best. So the objectives are to compare management options. I think before we talk about a role for non-hysterectomy or conservative management, I have to convince you that there should be a role for that, or that we have a need for it. I'll also introduce a possible role for delayed hysterectomy, which is that hybrid that I talked about, which is leaving the placenta in situ initially, but not forever. It's going back after a certain interval, once the blood flow to your uterus has decreased, to definitively then do a hysterectomy with hopefully less blood loss. And so that's a delayed hysterectomy. I will talk about the value of multidisciplinary approach to operative planning. It is a very deeply held belief of mine that surgery in general is a team sport, and that is never more true than in such a complex situation of placenta accreta. And then finally, I'll summarize questions regarding the optimal management, and again, leave us with more questions than answers. As I touched on, we know the incidence of PAS or placenta accreta spectrum is increasing. For reference, in the 1950s, the prevalence was 0.003%, which comes out to 3 per 100,000 deliveries. In contrast, recent systematic reviews and meta-analyses on the incidence of PAS at a population level show us that it's 0.05 to 0.12%, so 5 to 12 per 10,000 deliveries, so a huge increase. And when we break it down into severity, we often will talk about accreta, increta, and percreta, which also are called kind of similar to the FIGO staging, which is stage 1, 2, and 3 in severity. And just in basic terms, accreta is going to attach just to the inside lining of the uterus. Increta is going to be really into the muscle, and percreta is going to be through the uterus, often involving other pelvic structures like blood vessels or the bladder. And so when we look at the breakdown, we see that about 2/3 of PAS cases are what we call just accreta, or the most mild form. And that doesn't mean it's a good diagnosis. It just means it's a little bit less severe than the others. And then 1/3 comprise the increta and percreta. We know, and I mentioned this earlier, that the increase is largely related to increasing cesarean delivery rates across the country and across the world. And when we look at this graph, which shows accreta incidence quarterly from 2015 to 2017, we do see an increase each quarter. But it's so interesting in this same paper, when they took out patients who did not have a prior cesarean delivery, the yellow line underneath actually represents the incidence of accreta in patients without prior C-section. And so that's increasing in parallel to those who had a prior C-section. And similarly, we know that placenta previa, or when the placenta is implanted low in the uterus over the cervix, there's a higher risk of accreta, but the increase is happening also for patients without a placenta previa. And so this tells us that not only are our patients with the previa and the cesarean delivery history at risk, but really our entire population of potentially pregnant people are at risk for increasing rates of placenta accreta. And this is really important because placenta accreta spectrum has a lot of risks to a pregnant person. There are risks of hemorrhage, risks of ICU admission, prolonged hospitalization risks, risk of urinary tract and other pelvic organ injury, and even death. And so we all want to make sure that we are doing right by the patients, that we are doing the absolute best we can to prevent these bad outcomes. And it turns out that one thing that does significantly improve outcome is going to be prenatal diagnosis. And we do this using clinical risk assessment. So again, we know patients with the placenta previa and patients with prior C-sections are at risk, and also detailed imaging of at-risk patients. And this is often at the time of the anatomy scan and then sometimes throughout pregnancy. And the ultrasound image I have here shows typical features of a placenta accreta. So this arrow points to where the placenta is over the maternal cervix. We see big lakes or irregular bordered blood collections in the placenta. We look at the maternal bladder to see if the placenta is bulging into it or involving the bladder. And then we look to see if there's any blood vessels connecting from the placenta over into the bladder. And these signs would clue us in that we're dealing with an accreta process. And then we'd start an even more detailed ultrasound assessment to understand the extent of the disease. So now we have the diagnosis. And the next question is, so what do we do? And the current view of placenta accreta management is not straightforward. It's a bit confusing. Different guidelines, different societies have different opinions. And there's also significant regional and international variation in practice. In 2018, The American College of OBGYNs and the Society for Maternal Fetal Medicine put out an obstetric care consensus called Placenta Accreta Spectrum, where they asserted that the accepted approach is cesarean hysterectomy, and that all other management strategies, including those where we do conservative or expectant management, should be considered investigational. And so what that's saying is that you absolutely should always plan for an immediate hysterectomy, unless if you have approval from your institution under a research protocol or a research project to explore the other options. But in contrast, that same year, FIGO put out consensus guidelines on placenta accreta disorders, and they had an entire document on conservative management. And what they said was that leaving the placenta in situ or in place is an option for patients who want to preserve fertility. And that in those situations, you have to know exactly where the placenta is, and that's by detailed imaging, and that you need to have an expert surgical team on standby in case an emergency happens where a hysterectomy has to occur. The following year, the International Society for Placenta Accreta Spectrum took an even more liberal approach to expectant or conservative management, where they said, hey, we actually have data that this is associated with less blood loss and lower blood transfusion. This might actually be an appropriate strategy for a couple of patient types. Those who want to preserve their fertility certainly need to preserve their uterus, but also in cases where hysterectomy is considered to be a very high surgical risk for complications. So patients where the placenta is involving the bladder, patients where the placenta is going really far out in their pelvis and impinging on blood vessels and could cause hemorrhage. So with that history, it makes sense that we should question whether immediate hysterectomy should truly be the gold standard for accreta care. And when we look at what we know about the significant risks reported for immediate cesarean hysterectomy, we understand why we want something better, why we want to understand more what patients need, what type of surgery. And so in this table, we see, the common risks of accreta surgery, including large volume blood loss of 2 to 3 liters on median. And just for reference, at term, a pregnant patient has on average only 5 to 6 liters of blood in her body. So this is almost or more than half of her blood volume in a surgery. High volumes of red blood cell transfusion, high amounts of large volume transfusion, additional surgical complications, and then of course the risk of maternal death, which we really need to not have happen. And in response to known limitations of our current surgical standard, it's clear that over time, alternative strategies are becoming more common. And these include, which I've already defined for us, conservative management or expectant management, which is just leaving the placenta untouched, letting it absorb on its own over time. Partial placental resection or removal, which is excising or cutting out part of the placenta or part of the uterus with attached placenta. And again, we do not recommend that. And expert consensus recommends against that because there will be a lot of bleeding if we do that. And then delayed hysterectomy, and I'll get into that a little bit more later. Here's a graph from a cohort study, or sorry, retrospective study of tertiary hospitals in France, looking at accreta management from 1993 up to 2007. And what we see is a huge increase in conservative management or non-hysterectomy management of placenta accreta. And largely, so much of our data about this management does come from France and from other European countries who have been doing this for years. And it's so great that we have these experts to rely on, but it's also so important that when we're studying this and when we're reading these papers, we recognize that the healthcare system in the United States and in other countries is so vastly different. And so we have to take all of the information in the context of our patients and our capabilities. This graph comes from a study that's not yet published that we did out of Vanderbilt. And what we did was we queried program directors of all maternal fetal medicine, so high-risk OB and GYN oncology fellowships, to ask whether their fellows got exposed to treatment management options other than immediate cesarean hysterectomy. And what we found was about 1/3 to 1/2 of trainees in these high-risk specialties who care for Accreta patients are getting exposure to strategies other than immediate hysterectomy. We also found regional variation in practice, with those in the Northeast and the Southeast getting the most exposure. And then some further evidence of temporal trends. In 2012, a survey done of SMFM membership said that 90% reported doing hysterectomy for prenatal diagnosis, and that less than 1/3 ever considered or offered non-hysterectomy management. In contrast, in 2019, a large systematic review and meta-analysis of over 7,000 cases reported that only half, or just a little bit more, underwent hysterectomy. And then similarly, in 2021, we had another big study looking at hysterectomy likelihood that broke it down by Accreta types. And what they found was that about half of those with just Accreta have hysterectomy, whereas about 80% with Increta per Accreta undergo hysterectomy. Now, I don't think that this tells us the whole story of what's going on, because the truth is that when we have a prenatal diagnosis, we can plan ahead. Whereas when we have a intrapartum diagnosis, those are probably the cases where we're less likely to be ready and prepared and mentally there to do a hysterectomy in a lot of cases. And when I say we, I mean not only someone like me at a large academic institution with a lot of blood products and a lot of resources and backup, but also people out in community hospitals with less resources. And so this doesn't tell us the whole story, but it certainly tells us that there's options other than hysterectomy. So let's get into the data. I think it's really important when we're talking about conservative management, which I'll be honest, the idea of not doing a really complicated and high risk hysterectomy is quite appealing. I can understand why someone would be in a case and say, I just don't want to take out this uterus. It's going to be hard. And it's not that we don't like hard things, it's that we want what's best for our patient. So let's get into the outcomes. So this table shows a representation of some of the largest reports of conservative management outcomes. And the top line shows a study, this again is out of France, of 167 cases who underwent conservative non-hysterectomy management. And they reported a success of about 80%, meaning that just over 20% ultimately needed a hysterectomy. They had, a relatively stable major morbidity risk compared to other studies. And they really importantly gave us information on how long we can expect for it to take for the placenta to completely go away at 13.5 weeks, which is about 4 months. Did I get that right? In 3.5 months. And the other studies were a little bit smaller, had less patients, but also reported similarly about a 80% success rate of avoiding hysterectomy and about a 5 to 10% risk of major morbidity, which is going to be infectious morbidity like urinary tract infections, uterine infections, need for emergent surgery, need for blood transfusions, ICU stay, that kind of stuff. And so overall, these numbers are pretty promising for non-hysterectomy management, but something's missing. And you might notice that I have very obviously left out 2 rows of this table. And so what am I hiding? When we separate out, when we look at these studies in detail and separate out the patients who had the most severe form of placenta accreta or per accreta, we find a completely different story. We find that success is, the range is 14 to 58%, meaning that over 1/3 of patients are going to need a hysterectomy. Often the hysterectomy is either emergency during the surgery or emergent in the postoperative period over the course of weeks waiting for that placenta to resorb. And then additionally, the major morbidity is so much higher. Over half of these patients are going to experience major morbidity while waiting for the placenta to absorb. And then lastly, looking at the time to absorption in the study that asked this question, they had 2 times the length of time to absorption or to complete resolution in the 58% of cases that were successful. So that's about half a year of a patient waiting for this stressful, scary, impactful situation to resolve, also with a newborn. So taking together, my takeaway from this is that while conservative or non-hysterectomy management may succeed, this is most likely in cases without the most severe form of placenta accreta. And I'm really happy that we are continuing to study and learn from outcomes for patients who undergo conservative management. And this table comes from the Accreta trial, which was just recently published in 2021. Again, it's a study that comes out of France where this is happening more commonly, but it's the largest report of patients who underwent conservative management compared to those who underwent cesarean hysterectomy in the same time period over the same region. And these authors used massive transfusion that they defined as greater than 4 units of red cells as their primary outcome, and found that there was significantly lower transfusion requirements in the group who underwent conservative management. They also found that about 20% did end up needing a hysterectomy. And they also found that there was a higher risk of readmission in patients who didn't undergo a hysterectomy. And this makes sense because they had their placenta in situ, they weren't definitively managed. Now, in our practice at Vanderbilt, we don't advocate conservative management for the goal of fertility preservation. And we actually recommend tubal ligation or self-injectomy at the time of delivery if we're leaving the placenta in situ. But I do acknowledge that per society guidelines and per patient needs, this is often a reason that a patient would decline a hysterectomy in that they don't feel that their family is complete. And so that's a very real and realistic, reasonable reason that a patient would opt for conservative management. And so we have very limited data. I put it in quotes, largest cohort looking at pregnancy after Accreta diagnosis was 31 pregnancies and 27 patients. What they found, or what we see, is about a 90% pregnancy rate with a 62% live birth rate. And really importantly, about 1 in 3 had recurrent placenta accreta spectrum. So had to go through the diagnosis and surgical management again. So how do we pull this information together for our patients? Summarizing what we know about conservative non-hysterectomy management as compared to immediate cesarean hysterectomy, we know there's a range of success. We know that the success is going to range from about 60 to 80%, with the highest failure rate, meaning the highest need for hysterectomy, being in the Accreta group. We know that there's a range of severe morbidity and that this is going to be much higher, above 50% really, in the Accreta group. And we know that if a patient does pursue future pregnancy, there's going to be about a 1 in 3 recurrence risk. So with all of that, we wonder if there's a role for delayed hysterectomy in patients who elect conservative management with the goal of reducing risks of hysterectomy, but in whom are not pursuing future pregnancy. And so what I will assert is that doing a delayed hysterectomy offers definitive management, but potentially reduces severe morbidity and mortality from the immediate hysterectomy. What this allows us to do is to perform a hysterectomy with significantly less blood loss. And I am going to show an image. And so for anyone who wants to turn away, these are surgical pictures of hysterectomy uteruses that were taken out at hysterectomy. I think it's important that if, some people do like to see this and it's really helpful, picture worth 1,000 words, some people don't. But what I'm going to show is that at the time of an immediate hysterectomy, meaning you're doing a cesarean delivery and doing hysterectomy right then, there's a large bulky placenta and there's a ton of blood flow, about a half a liter going through the woman's body every minute. Whereas if we deliver the baby, cut off blood flow to the placenta, and wait 4 to 6 weeks for that blood flow to kind of go away and the placenta to shrink down, we can do a hysterectomy with a lot less large blood vessels and hopefully a lot less blood flow. So I'm going to show these pictures now. And so on the left, we see the immediate cesarean hysterectomy specimen where we see a large bulky placenta in the lower part of the uterus. And then on the right, we can see the delayed hysterectomy specimen, which was at 6 weeks after delivery, where there's just a lot less redness and a lot less bulky protrusion. And so following the 2019 ISPAS report that said we can consider conservative or non-hysterectomy management for cases where not only people want fertility, but also where hysterectomy is high risk, we published our data out of Vanderbilt after having a protocol or a clinical algorithm that allowed us to consider delayed hysterectomy for severe placenta accreta. And I really loved the editorial that was published along with it, which asked, are you crazy? Are you doing 2 surgeries when you could just be doing 1? And I think that's a super valid question. Each surgery poses risks, and anytime we do any procedure on a patient, it has to be in the setting that we truly believe there's a benefit to the patient. So in answering this question, I encouraged these authors and encourage our team to focus on severe cases, to engage in detailed counseling about the options of immediate cesarean hysterectomy, conservative management without hysterectomy, or conservative management with delayed hysterectomy, and ultimately employ shared decision making. And so I think, it's important for us to talk about our outcomes with delayed hysterectomy. And really briefly, this table on the left comes from our paper where we compared the hysterectomy portion of delayed hysterectomy versus patients who underwent immediate cesarean hysterectomy. And we found that we were able to accomplish a delayed hysterectomy in about half the time. We were able to accomplish it with about 1/4 of the blood loss. And as a result, we had a significantly lower portion of patients who needed large volume blood transfusion. When we compared our estimated blood loss with reports from large centers who are expertly doing Accreta care and doing immediate hysterectomies, we found a lower estimated blood loss for our hysterectomies. And this was similar to data that came out out of Duke, who also has a protocol allowing for delayed hysterectomy. They have similar results to ours. But really, really important, there are risks that we have to acknowledge when we're leaving a placenta in place and just removing the baby. And these biggest risks are going to be infection. So when you leave a placenta inside, it's a nidus. It's a spot where an infection can develop. And a uterine infection can be really dangerous, can cause a need for readmission, need for antibiotics, and ultimately will need a hysterectomy to treat it. And so we did see increased risk of infection, and we found that the infection occurred post-delivery with the placenta in place, but also in the post-operative period after hysterectomy. And those were mostly surgical site infections and urinary tract infections like bladder and kidney infections. And then the other thing that we found in our study is that we did have incidences of blood clots, so DVTs in the legs, pulmonary emboli in the lungs. We had that occur in 1 patient after delivery and 1 patient after hysterectomy. And we know that blood clotting is a complication of surgery where patients are immobilized for a long period of time. So having 2 surgeries, it makes sense that would increase the risk of those complications. And then I'm kind of going to just breeze through this because it's not super important, but it's important, but doesn't contribute that much to the story. It just tells us again, what we don't know is that centers that are doing conservative management don't just deliver the baby and leave the placenta in situ. They do a bunch of other things to try to promote placental regression or to stabilize the patient. And I think it's really important to know that in each of these studies, there were so many different things that happened in different amounts that even if looking at these studies, we decided that we should do conservative management, we'd still have so many questions about how best to do it. Should we be doing embolization before surgery of the vessels? Should we be tying up the vessels? Should we use urinary or ureteral catheters? Should we use chemotherapy agents? The answer to that is no. But should we be using prophylactic balloons and just so many different things and procedures that we're doing that ultimately it leaves us wondering how the best way to do this. And so it kind of leaves us with a picture that looks like this, that even if we do want to do conservative management, we still have so many other modalities or treatment options to investigate before we know the best way to do it. So you might be saying, okay, I see where you're coming from. It seems like there are some benefits. It seems like there are some risks, but like, what do the patients say? Like, this is so important, right? I haven't yet mentioned how patients feel about this. And so this is something that we're actively investigating at Vanderbilt, and we're investigating it by not only looking at their depression scores after delivery in the hospital, which we take for all postpartum patients, but also by doing telephone interviews of patients who have undergone different types of management, because it's so important to the story. And so the first thing, as we're looking at additional patient outcomes, is what % of these cases are done scheduled and what % are done urgent or emergent. And what we found was that there's no difference between immediate and delayed hysterectomy in our population, or no significant difference. But ultimately, about 1/3 of our patients are getting delivered in unscheduled cases, meaning they come in bleeding or in labor. And as a result, they have about 1/4 are taken care of by anesthesiologists who are not trained in obstetric anesthesia. And then when we look at patient-centered outcomes, I think this is pretty compelling, is that patients who undergo immediate hysterectomy did have lower postpartum depression scores. And our patients who underwent conservative management did describe feelings of anxiety, feelings of trauma, feelings of stress, which are not unexpected in such a severe diagnosis, but were worse than our patients who underwent immediate hysterectomy. And I think it's difficult to generalize to every single patient and say, like, well, that settles it. Patients like immediate hysterectomy better. I don't think that's the answer, but I do think that there's something to be said for the prolonged hospitalization that happens after a delayed hysterectomy or after a conservatively managed Accreta. And just looking at the difference in how many days a patient will stay in the hospital, how close they have to be in touch with medical care, and how on edge they are leading up to definitive treatment if they undergo it or resolution, really does have an impact on the psychosocial health of the patient and her family. And then lastly, I'd be remiss if I didn't mention that 2 surgeries is 2 admissions, is 2 ORs, is about twice the cost. I don't know that we are in a place where we'd be making decisions on this really severe diagnosis based on costs, but it's something that we think about in medicine. And so our numbers are small, but it's really important to start somewhere and to ask the questions. And so our numbers are small. With others, they can be powerful. This slide just shows a lot of societies and groups and meetings that we've been encouraged to work with, that have been interested in hearing our work and also published with us. And so I'm just really grateful for such a great community of people who care so deeply about Accreta. For the last few minutes, I'm just going to go through how we do delivery without hysterectomy. So how do we actually do a C-section and leave a placenta inside? And it's not that simple. It requires a lot of preoperative planning. And I mentioned this is a team sport. It is like a lot of team members. And so preoperatively, our patients meet with maternal fetal medicine, neonatology, GYN oncology, social work, sometimes perinatal psychiatry, depending on their needs. When they are admitted, they meet with our anesthesia experts, they meet with urology, they meet with general surgery, they meet with our blood bank. We talk to our ICU in case we need their bed. We talk to interventional radiology in case we need embolization help. And we have a multi-team pre-brief in the day or two before the case, just to make sure that all of the patient's medical history is known and that all teams have their questions answered and that the patient has their questions answered. On the day of surgery, every team has a really clear role in patient preparation. And similarly, intraoperative care is detailed and very role specific. And we're just in constant communication to make sure that everyone knows what's going on, how's the patient doing, and whose turn is it. I will say for the majority of the surgical, the delivery and the surgical assessment is going to be maternal fetal medicine, and then with gyn-onc support for their expertise in pelvic surgery. For our surgical approach, we go up and down on the skin. We use an ultrasound to map the placenta so that we can deliver the baby far away from it and not disturb it at all. And we've actually started using what we call our open fetal surgery technique, which is a technique that we use when we're doing surgeries on babies in utero that we want to stay in utero. So to fix spina bifida, for example, we open the uterus, repair the baby's spine, close the uterus back up. And the goal is to allow that uterus to stay pregnant and not go into labor and to grow. And so that's a similar surgical strategy we use for these Accreta cases, with the idea that we're not disturbing anything. We're just kind of like delivering the baby, pretend nothing happened, close it back up, nothing to see here, and try not to get the placenta to separate. And so I do have just 2 slides of images from us in the OR, nothing super gory. But this is an image of us with a uterus exposed on the operating table using a marking pen and an ultrasound just to mark where the placenta is so that we keep our incision well away from it. And then here's a image of us kind of marching down with our surgical clamps to expose the amniotic membrane. And our goal with delivery is to have as little blood loss as possible. And in our study, we actually had very low, like negligible blood loss for these cases in the absence of doing a hysterectomy. Clinical decision making actually happens in the OR. So it's on prenatal assessment, we'll use prenatal imaging, detailed counseling, and shared decision making if we think the patient has a severe enough disease to think that a conservative delivery might be warranted. But it's really not until we're in the operating room that we assess, can we safely do a hysterectomy, in which case that's our preference, it's definitive management, or are we going to delay or leave the placenta in situ? And so some patients, after hearing everything that I've just told you, say, absolutely not, I just want a hysterectomy, I can't do this for several more months. And then that's what we do. Some patients say, yeah, I'd like you to try to leave the placenta in situ. And so for those patients who accept that, then we do intraoperative assessment. And that includes cystoscopy, looking in the bladder to see if there's any bladder involvement of the placenta. And then we do a pre-delivery exam, meaning we have the belly open, but we haven't yet delivered the baby. We're looking at where the placenta is. We're looking at what the uterus looks like. We're kind of thinking, can we safely remove this uterus if we wanted to? Or should we really just leave it be and come back later? And then a post-delivery exam where we make sure that bleeding has stopped, everything is stable, and we can safely leave the placenta and close up. After delivery with the placenta in place, patients get broad spectrum IV antibiotics. We use Zosyn for 72 hours. We do allow our patients to express breast milk. Some people have concern that pumping or nursing will cause uterine contractions. We have not found that's increased bleeding. And it's also something that is really important to patients, and especially when they have babies in the NICU, which is often the case since we do these around 34 weeks.
It looks like we might have lost Dr. Zuckerwise. So if everyone could just give us a moment, we'll work on getting her back in the live stream. Meanwhile, while we work on that, please continue to leave your questions and comments in the chat so that we can make sure that we have time for some Q&A with her at the end of her presentation.
Hey, can you hear me? Can you hear me?
Sorry, yes, I can hear you now. You're back.
Yeah, where did you lose me? Because I heard you the whole time.
Oh, okay. I have your slides back up, and it's back on your first slide, so you need to advance to. You were right around the.
Was it postoperative care?
Yeah, it was only 15 seconds or so.
Okay, great.
That we lost you. So.
Oop, okay. All right. Is that where we were? Does that sound good?
For some reason, I'm not seeing the slides advancing now. I'm just still seeing your cover.
Hold on 1 second. Okay, here we go.
Okay.
How's that?
Perfect.
Okay, great. So when I heard Jory, I was talking about postoperative care, and just to recap, we use broad spectrum antibiotics for 3 days. We allow our patients to pump. It's really great for them and for the babies in the NICU. And they stay for 7 days or until they're meeting our strict discharge criteria. So meaning that they have no signs of infection, no signs of bleeding, that they have a working phone, adult who can stay with them, and that they can get to the hospital quickly if they need to. We see them about once a week. We check their labs to make sure there's no signs of anemia or infection. We typically will do an MRI at about 4 weeks and make the plan after that for definitive surgical management if we're doing a hysterectomy. And then just a few lessons we've learned intraoperatively. We spend a lot of time getting our patients set up, draped properly so that we can assess for any bleeding, assess for stability, do the surgery meticulously. We map our placenta with ultrasound, and we're really careful when we make our incisions so that if we decide to leave the placenta in situ, it's hopefully going to stay. In terms of postoperative care, as I mentioned, breastfeeding or pumping if the baby's in the NICU is really important to our patients if that's what they want. And we have not found that that's increased bleeding. We really emphasize close follow-up and compliance plan, and this is all the way through resolution. And then I think we can even continue to improve our longer-term follow-up because, again, this is a condition that really has impacts down the road for the whole family. And then we've learned over time just that timing the hysterectomy for about 4 to 6 weeks after delivery is the ideal time. So just some final concluding thoughts. Immediate hysterectomy remains the most common strategy for placenta accreta, but alternative strategies are increasing. And there's pretty compelling data that they're at least a reasonable option to talk about in a lot of cases. We do know that expectant non-hysterectomy management is less likely to succeed in the most severe cases of Accreta. And so these might be the patients who uniquely benefit from definitive treatment with delayed hysterectomy. Ultimately, my real belief is that we need to continue to research this to determine the optimal approach for placenta accreta management. And this is going to include hearing patient stories, getting the patient voice, and just continued collaboration across many centers so that we can increase our numbers and really understand which patients benefit from which approaches. I don't think there's ever going to be one answer, but I think there's going to be a time when we're offering better counseling and more options to our patients. So thank you so much for your attention. Thank you for the patience with the technical issues, and I'm really happy to answer any questions.
That was just amazing. Thank you so much. I think we were all just riveted, learning from you and listening to you, and this is great stuff. I loved seeing all of the recent studies too. I actually wasn't familiar with a lot of that information, and it's so great to see that more people are asking these questions and getting involved. And what I wanted to say too that I think is an important aspect of conservative management and something that you iterated multiple times as well, is this isn't just about preserving fertility. While that can be a side effect of conservative management, really, this is about pursuit of the safest treatment options, and especially for women who have the most severe cases. So from my perspective and National Accreta Foundation, we are just thrilled to see that people are kind of taking a step back and looking at, okay, well, just because we've resorted to hysterectomy for the majority of patients previously, what is the right path here? And how can we do the best for these women and their families? So thank you so much for your work towards this. I have many questions.
Hey.
I wanted to say too, I love that slide that you have where you're contrasting the guidance from ACOG, from FIGO, from the International Society. It's so interesting to me to see all of these well-experienced and well-researched institutions that can have very different approaches to this. So in your work, in being kind of one of the people bringing conservative management forward, how is that received in professional experiences kind of outside of the close-knit Accreta community?
This is an amazing question, and it makes me feel seen. When we were writing our paper and trying to get it published in the Grade Journal in 2020, there was a lot of, thanks, Beth, hi. There was a lot of pushback. And when we submitted the paper, I was warned. I was kind of a junior attending at the time, and I was warned that this was going to be an uphill battle. This is not something that specifically Accreta specialists in the United States are comfortable with or want us necessarily advocating for. And it was really important that we wrote this paper in a way that said, we're not suggesting that we know the answer, we're just suggesting that it's okay to study. And it was a really uphill battle to get it published. And afterwards, the overwhelming response was, hey, we do this too, we just don't talk about it, from a lot of other places around the country, and a lot of people calling to ask, like, can we talk about this? Because we kind of haven't talked about it. And so in response to that, which I thought was really cool, a bunch of the Accreta docs, as you know, speak at SMFM every year at our national meeting. And after this paper, invited me to give a talk on conservative management. And the first year, it got a lot of questions and rumblings, and it was a little more controversial. By the second year, when they invited me back for some reason, people were increasingly more accepting of it. And then I think it kind of, the fact that we're talking about it on a national stage, we're talking about it on an international stage, it's something that we can't ignore anymore as at least an option. And so I think that it's something that's taken a long time for people to not talk about in a way that to make it feel taboo. But I think it's really important, because I do believe that even if it's not the one answer, it is an option.
Absolutely. One of the things early on in your slides as well that I thought was really interesting was the graphs that you showed when you were breaking out the cases that did not have a prior cesarean delivery and the cases that did not have placenta previa. I mean, usually we know that as those are the biggest risk factors. So the fact that we're seeing increases to Accreta even for women who don't have a history of cesarean delivery or placenta previa, what do you take that to mean?
Yeah, I mean, I think there's a lot of additional risk factors that probably add up, a lot of small risk factors adding up in bigger numbers. So for example, we know that tobacco use, we know that advanced maternal age, assisted reproductive technology, those are all risk factors for abnormal placentation, as are prior uterine surgeries to patients who have had multiple D&Cs if they've had losses, patients who have had uterine surgeries to remove septums or fibroids. Anytime we have disruption of that uterine lining, there's a theoretical increase or a potential increase in risk of Accreta. And so I think that as we are getting better at patients getting pregnant, and as we are also experiencing aging, and I don't think advanced maternal age is old, it's not old, I know it's not, but as we see patients pursuing pregnancy later in life, they are at a baseline higher risk. And so I think that's what it's reflecting.
Interesting. And that's actually a good segue to one of the next questions I have too, is we're getting better at getting women pregnant. We're getting better at diagnosing Accreta as well. And so that leads me to a question that from one of the slides that you showed, that comparing the hysterectomy rates between those with Accreta, Increta, and Percreta, and that it looked like the majority of the cases that were able to escape a hysterectomy were the Accretas. What are your thoughts in context of that with overdiagnosis? How many women that we're saying have Accreta and are able to avoid that hysterectomy and potentially the pathology that would confirm their Accreta as well? So I'd love to hear your thoughts on overdiagnosis.
Yeah, we just heard about this at PAS Squared, I think. So it's fresh on all of our minds, but we are definitely have not optimized our even definition of placenta accreta. And so I agree with you. I think that this is a problem in our methodology of studying it when we don't even know what constitutes the disease. And so I would agree with you that those studies can't necessarily be used as definitive information, because very likely those cases are adherent placentas, are stuck placentas, or what some people will call focal accretas, where you can actually scrape it off or manually remove it. That we, in the absence of hemorrhage, could potentially avoid hysterectomy. And then, just like you said, we don't have the specimens, so we can't confirm or refute what we call it. I know that a lot of people in the Accreta world are actively working right now at improving a standard diagnosis of Accreta that takes into account clinical features in addition to histology or specimen features, because as we can start doing more conservative or alternative strategies, we lose that hysterectomy specimen as our final answer. So we need to make our diagnosis clinically applicable, that it could be used in cases with and without a hysterectomy if we want to compare these.
And I wanted to thank you too for the call out, because I was thinking this question before you addressed it, and then you so well addressed it. What do the patients think? And so going through, I'm glad to hear the amount of effort that you're putting into following up with these patients, understanding what their experience is, and the increased rates potentially of postpartum depression, the increased hospital stays. And I myself actually was a unintentional conservative management attempt, and I did end up experiencing an emergency and required hysterectomy, as unfortunately many of these women do. And so I just wanted to bring some attention to of how conservative management is really an interesting path. And I wasn't surprised to see the increased complexity of mental health associated with it, because as scary as it is having an Accreta diagnosis and building up to that delivery date, in conservative management, you get the baby out, which is great, but all of the risks and all of the concern and anxiety surrounding that delivery are still there, and potentially for an unknown amount of time as we see how that course goes. So how do you address that with having such a high amount comparatively of conservative management cases? How do you help these women prepare for and get through these experiences?
Yeah, I mean, it's so important, and it's also hard. I think you can counsel as much as you possibly can. You can, connect them with people who have been through the experience. You could have them meet with our social worker, have them meet with a perinatal counselor, do all of the things. And as anyone who's had a pregnancy knows, whether it's complicated or not, afterwards, there is a complete shift in everything about how we think, how we feel, how we act about things. And I think it's something that we just have to be open and honest with, and constantly check in with, how are you doing? How can I support you? These are our resources, but do you need something else? And I think, in our situation, we've only had, it's very rare that a patient says, I want this because I don't want a hysterectomy. It tends to be that we will do a hysterectomy if we safely can. And if we feel that an immediate hysterectomy would be truly life or organ risking, then we leave it in situ and go back later. So just to be clear, at Vanderbilt and in my experience, I am not counseling patients, you have two options, they're equal. Yeah. I am counseling patients that when we can definitively manage this condition, we do. And when we need to kind of take a step back and do something more like trauma response, which is if someone has a major trauma, you go in, you stop all the active bleeding, but you don't necessarily put everything back together. You just kind of take it in stages to take care of the main issue at hand, which is delivering the baby safely and lessening blood flow to uterus, and go back when things have stabilized.
Absolutely. And I think that that's an important point too, is that really, there is the potential for better outcomes with this path as well. And in these severe cases where there isn't a clear, easy answer, it can add to the complexity. So since we've gone through, we've learned a lot about conservative management and how it's a tricky approach. So who is the best candidate for it?
That's a hard question. We were just talking about it at our residency journal club last night. In my practice right now, I think that in order to be a candidate for conservative management, it has to be someone who has really strong conviction to avoid a hysterectomy. That's important. If someone says expressly, I decline a hysterectomy, I need the option to keep my uterus, I need the option to have more babies, or just not to lose my organ.
Yeah.
That has to be a compelling need of theirs. Because if we can, again, safely just treat the condition, we probably should at this point. But that's not right for everyone. So a patient who expressly wants that, a patient who is able to comply with close follow-up and has access to care. So we take care of patients from a lot of different geographic areas, and we spend a lot of time figuring out how to keep them close to us, because I can't have a patient 2 hours away start bleeding and go to the nearest hospital. They need to come back to a place with expertise in the surgical management of Accreta. So we need a patient who is socially and emotionally, family-wise, resource-wise, able to stay by us or willing to let us provide resources to do so. Now, as we know, the majority of patients who are experiencing this diagnosis have other children. And that's a really important thing to factor. It's not penalizing someone for being a mother. It's not penalizing someone for having a need to work, to support their family, to take care of their family. It's again, an honest conversation about what is required of a patient who has a placenta in situ. It's a lot to ask. And then it needs to be, again, a patient who has engaged in shared decision making and accepts that. And then on the flip side, there are patients in whom I think an immediate hysterectomy would be acutely life-threatening. And then we don't have the benefit of that shared decision-making conversation. We have the benefit of expertise in knowing how to do this as safely as possible. And we feel relieved that they're in our care. Thanks, Carrie.
And then what advice do you have for a patient who's interested in exploring this option? And what if this is something that their local hospital maybe doesn't have experience with?
Yeah, I think if and when a patient is diagnosed with an Accreta, it is so important that they feel empowered to advocate for themselves. There are a lot of places. Vanderbilt is not unique. I mean, I think it is because it's my home right now, but there are so many, both large academic, but also busy community practices that have a lot of resources and a lot of experience with this, but there's even more that don't. And so I think it's very important to ask your physician who's diagnosing it, and to graciously thank them for diagnosing it, and then to have an honest conversation. How many of these does your hospital take care of a year? What is the surgical approach? Can I meet the surgical team? Who are the experts? Are there any other regional experts? I think that the PAS squared, Pan American Society of Placenta Accreta, has a map of all the involved centers there. I think that's a great resource for patients because it shows not only institutions that are doing research and joining a network, but are also doing clinical work and passionately involved in this. And so I think, reaching out to experts is the way to go when you have such a severe diagnosis. And so I would encourage patients to talk to their teams and to be open to sharing care with a center that has experience with this condition.
Absolutely. And I'm going to put in a plug, actually. National Accreta Foundation did a collaboration document with the Pan American Society on second opinion. And so that's something that patients can find on the National Accreta Foundation website that has some great questions to ask and help to guide those conversations. One more thing I wanted to touch on before we go into the viewer comments and some questions that were submitted in advance. You mentioned chemotherapy medication, no longer recommending that. We do see questions for this, so I just wanted to make it super clear if you could explain the
Absolutely.
use or non-use of methotrexate.
Yeah. Absolutely. So back when I was in training, this was something that still was being done. And the quick answer and the basics of it is that chemotherapy works because it stops the dividing and the growth of rapidly dividing cells. And so when you have a cancer, it is rapidly dividing cells kind of out of control. You throw chemotherapy agents like methotrexate at it to stop the division. Placental cells and pregnancy tissue is also a rapidly dividing and growing cell or line of cells. So this is why methotrexate is a great treatment option for things like ectopic pregnancy or conditions where the rapid proliferation and growth of pregnancy tissue is harming maternal health. So it makes sense that when people were exploring options for how do we get this placenta to resorb as quickly as possible, that they would use this medication. But what we've learned is that after delivery of the baby and cutting off that extra need for blood flow to the placenta, adding methotrexate doesn't hasten placental resorption. And methotrexate, like all chemotherapeutic agents, has a lot of risks, has toxicity, can affect maternal organs and maternal health. And there's actually, in a case series looking at this, there was even one case of maternal death related to methotrexate use for Accreta, not related to Accreta. So it's the combination of recognizing it's a medication that has risk and it's a medication that has no proven benefit in this condition, that it is, according to expert consensus and best available data, it is not helpful.
Thank you so much for clearing that up. This is a fantastic resource for our patients. Okay, so let's move on to some of the questions that were submitted in advance. And folks, this is a great call to anyone who's watching who has questions for Dr. Zuckerwise, either on conservative management or about placenta accreta in general. Please feel free to chat them in and we can address them. So one that I wanted to bring up that was submitted in advance by Lucy. And Lucy says, I'm a lactation counselor in a NICU where we're seeing moms receiving conservative management for Accreta with the placenta being left in situ. And I wanted to know, what is the best advice I can give these moms regarding pumping and their potential milk supply? And also if there are any contraindications for breast pumping or breastfeeding.
Yeah, you know, and there's another, Danielle just put a question as well,
Yep.
that retaining the placenta can affect lactogenesis. And it's true that anytime a pregnant person undergoes a major stressor, a major surgery, an episode of major blood loss, all of these can impact milk supply. And I do not have, large enough numbers to talk about milk supply quantity, duration of lactation, or, who does and who does not continue breastfeeding. But what I will say is that our patients who have immediate hysterectomy and our patients who have the placenta left in situ are both encouraged to start expressing breast milk, ideally within hours of delivery. And what we know from studies of babies in the NICU and moms who are pumping, because again, we do these cases at 34 to 35 weeks. So most of the babies do go to the NICU. What we know is that early initiation of milk supply, of lactation, is going to produce significant increases in blood supply. And so this, it just makes sense then that we get these patients pumping as soon as we can and as soon as they're able. Now, realistically, I will say that after a cesarean hysterectomy, it's not always the first thing on the patient's mind. So again, I use the pre-delivery counseling period and the visit before, the day before surgery, or in the office, to talk about whether breastfeeding is something that is important to the patient, whether it's something that they even plan to do. And for patients who express that it is an important value, that's often something that I'll kind of assign to their partner or who's ever their support person, whether it's a spouse or a mother or a sibling, and say, they're going to forget how important this is to them, but we're all in here together saying this is something that they really, really value. So I'm going to make it your job to make sure that that breast pump is in the room when they get back from the operating room, and just remind them to hook it up, maybe help them hook it up, maybe be the designated washer of the parts. and kind of delegate that out so that they can just give it to the recovering patient. And it also helps. We are so helpless in so many situations that we have no control over related to Accreta. But I think it also helps the support people kind of have a designated role when they're kind of just like, what do I do? How can I make this better? And so in terms of absolute quantity, I don't have an answer. We should study it, and thank you for that suggestion. I will. But I do think that, so much is taken away from patients with an Accreta diagnosis that giving them breastfeeding completely or partially or however they want or can is a gift that we should give if that's what they want.
So well said. Thank you. I see a question here from Madison Misko. If the placenta is left in the uterus and the cord is left unclamped, what prevents maternal bleeding through the placenta and cord? And is embolization of vessels done prior to close?
That's a good question. So the maternal and fetal circulations are separate, but you're right. Maternal blood flow does enter, or maternal blood does bathe the placental villi and come into the uterus or into the sac to feed the baby. What we do is we doubly tie off the umbilical cord. So you might know, after you deliver a baby, anyway, we always clamp the cord, cut it, and hand it off to the baby. The clamping is actually the most important for the baby because it prevents them from bleeding out. But clamping off the placenta kind of closes off that circuit to allow maternal blood from entering continually to the placenta. So we suture it, we just tie it.
Okay. Going down again, please feel free to comment with your questions. We got a few more that I see that we can get to as well. We have Sam. How often do you feel that hysterectomy can be avoided in cases of focal accreta?
Yeah, another really good question. And it's very case specific. I think if there's a area where the placenta is attached and it is small, it can be just completely resected and sewn up, kind of as if you removed a fibroid, like that. That's a very reasonable approach. If it's a focal accreta that is, bigger, several centimeters, and if we try to remove it and there's associated hemorrhage or active bleeding that we can't stop in itself can be an indication for a hysterectomy, even in the absence of accreta. And so I don't have a number in my head in terms of how often it can be avoided. I think if we have a prenatal diagnosis, we're more likely to be able to avoid disruption and maybe just allow for a focal resection. Whereas if we don't have a prenatal diagnosis and we're trying to remove it, we're having extra bleeding, we get into a situation where the bleeding is becoming unsafe. That's when a patient with a focal accreta is more likely to have a hysterectomy.
And so diagnosis, so we were mentioning how that is such an important part of accreta treatment, yet many cases continue to go undetected and undiagnosed. Can you speak for a little bit just about the complexities of accreta diagnosis and if you have any facts or numbers about how often that happens?
Yeah, so I mean, nationally and internationally, it's accepted that about 50% of placenta accreta diagnoses are made at delivery. Now, like you were saying, Kristen, that a lot of that has to do with maybe we aren't meticulously defining placenta accreta. But I will say in studies looking at centers with expertise in imaging, we have about an 80% detection rate for accreta, and that is even higher when it's in the setting of placenta previa, which is a clue to look for it. The hardest cases, the ones that we miss the most, are going to be the ones not associated with the placenta previa because it might not be as high on your mind, and it's also a lot less likely. And also those that are associated with a posterior placenta, so not associated with a prior C-section incision. And also just in a location where when you're doing an ultrasound from on mom's belly, it's going to be harder to see. Those are situations when it might be beneficial to get an MRI if we can't get good imaging in an at-risk patient with a posterior placenta. Those are some of the rare cases where me as a big ultrasound proponent might say we have something to learn from an MRI. And then lastly, I'll say that it also is really sonographer and sonologists. Sonologists are physicians who read sonograms, but and radiologists who read the MRI. it's a function of their level of concern, their perception of risk, and their experience with looking for signs and then, discussing with the clinician. So again, I think this is a way that patients can be our best advocates, and that doctors can also, make sure that patients know how to advocate for themselves. And so, for example, patients who have had multiple miscarriages, to know that they've had 6 DNCs, that's something they have to remind their obstetrician every time they're pregnant. Or someone who's had a uterine septum removed, someone who's had multiple fibroids removed and then conceived by IVF, that we should again be talking, goes back to not talking about Accreta enough. That if a patient says, I'm at risk for Accreta, it's going to be written in their chart and we're going to look more carefully. And it's just really like getting it in everyone's mind so that we miss it less and can prepare more.
Exactly. I saw an interesting question come through as well about menstruation returning post-conservative management. Anything you can say about that?
I will say that, the time to resorption of the placenta does not equal the time to ovulation. Though no, we do not have good literature as to when, menstruation resumes. And then the other complicated thing is that with a placenta in situ, there's often going to be days of spotting, and it's hard to know if that's placental or endometrial. I would say it's really unlikely to have a normal period until the placenta has completely resorbed. And so the other thing is that after delivery with a placenta in situ, you've gone through the fundus of the uterus, like the top of the uterus, which is the contractile muscular part. There needs to be at least 18 to 24 months before pregnancy is even considered. So the other complicating factor in answering this question is that I would recommend all of my patients be on some form of contraception, whether it's an implant in the arm, depot shots, oral contraceptive pills, patch, ring, whatever, not an IUD, obviously, because the placenta is there. But we need our patients to be on contraception, and that's going to further complicate figuring out what happens to periods after conservative management. So I don't know the answer to that, actually.
It's good information. Actually, that makes me think of a question too. When we say the placenta gets reabsorbed, what does that mean? How does the body take this big, massive placenta and make it disappear? What happens there?
It just does. It just does. I mean, it just goes away. A lot of patients do have episodes of discharge or shedding that can be like a kind of like a period, like brown discharge tissue. So there can be pieces that come out, but a lot of it really, the majority of the mass of it just gets like quote resorbed, which is by our body's scavenger system, the same way that if you have every time you ovulate, there's a little bit of bleeding and then it goes away, forms a clot and gets absorbed.
It's amazing. It's really fascinating. Okay, so I had another question too that I wanted to finish up on as well. Is, in your opinion, what is the next best thing, and the next big thing that's coming in Accreta treatment protocols or standard of care?
I hope that the next big thing is psychosocial support, like an actual document from stakeholders, so Accreta doctors, Accreta patients, that puts together a toolbox or a standardized list of ways to emotionally support Accreta patients. And I think that the first step to that is going to be extending maternity care beyond just pregnancy, and recognizing that the 6-week visit will not suffice for this situation most of the time.
So true. There's so many opportunities for improvement just within so many aspects of maternal health care specifically, as well as placenta accreta. And I would love to see as well. I'm glad that there is so much more interest in the patient experience and understanding the complexities from a patient experience standpoint of placenta accreta. And I'd love to see more collaborations with the Pan American Society and more joint publications, and more involvement from our patients, from those who are watching this and want to get involved and use their experiences towards making outcomes better for future moms. So thank you so much, Dr. Zuckerwise. This has been wonderful and fantastic, and we really appreciate you coming here and sharing all of your knowledge with us here today.
Thank you so much for having me. It was a pleasure.
Thank you.